This is BMI Redefined with Jen and Mo.
All right. Welcome to BMI Redefined with Jen and
Mo.
And today we have a really exciting guest with us. It's Dr. Bill Jiranek, orthopedic surgeon at Duke University. And his clinical practice focuses primarily on treatment of hip and knee joint disorders and arthritis. Research interests include tissue-guided restoration of articular cartilage of the knee, joint infections, and the body's immune response to biomaterials, and innovative practice and funding methods. He was a previous president of the American Association of Hip and Knee Surgeons, and he also performed 3 of my surgeries, my orthopedic surgeries after my car wreck, including a total hip replacement, and yes, I still water ski. You do great work. So today we're so excited to talk with him, and we're really going to get into medical procedures and mindset and kind of what is the intersection. And I know, Bill, from my being your patient and from conversations that we've had, that you're really interested in the mindset of the patient, you know, what's going on in their mind, in addition to the physiology and the pathology. So you had brought up something the other day when you and Mo and I were talking about attitude. So would you kind of share with us your thoughts on attitude and treatment plans?
Well, I think attitude can mean a lot of different things, but one of the things that I think really helps patients are resilience skills. And that means being able to see that the glass is half full and being motivated to try and fill up the rest of it. And not everybody goes into this that way. You know, sometimes you're afflicted with a condition and it's why me and woe is me. And I think if we can turn the tables into a more positive attitude, it tends to really pay dividends in terms of people's outcomes. The other thing that I think we've become more attuned to is people's overall mental health and how that affects organic conditions like arthritis. And the answer is fairly dramatically. And it not only affects them when they're being treated medically, it affects them when they're being treated surgically. And so we spent a lot of the last 15 years figuring out what you do with somebody who pain catastrophizes. In other words, they start to get pain and they accelerate, more and more nervous, and pretty soon pain has control of them. What do you do when somebody's badly depressed and they think that a knee replacement will bring them out of their depression? It doesn't always work that way. So I think that most physicians have become more attuned to picking up on those clues, whether it be apprehension or depression or catastrophizing. I think there are now tools out there that we can use to identify patients that might have trouble and might need more intervention on the psychosocial side before they ever have much intervention on the arthritis or the surgical side.
Mm-hmm.
So that's a mouthful, but that's kind of, I think, where our profession is moving. I hope treating the whole person, and I think we've already shown that if you do that, your overall outcomes will improve. So.
Do you encourage your patients to seek, not all of them, but the ones that you feel need that extra help, to go have some counseling before the surgery or perhaps after?
Mm-hmm. Absolutely. And I think we build networks. We have built networks at Duke to try and create those referral paths, and not to make it a stigmatizing thing. You know, counseling used to be stigmatized. Nobody wanted to say, oh God, what's wrong with you? You went to counseling. Now everybody goes to counseling. And I think that's part of the overall understanding of how we all work, that has improved. So yes, the answer is sometimes we'll delay surgery and work on things that need to be addressed first.
Yeah. Yeah.
Well,
Yeah.
and physical therapy runs into that same vein as well, because you would have patients do physical therapy because you said surgery is not always the cure, that sometimes there's some type of non-invasive treatment as well.
Absolutely. Yeah.
Yeah.
So Mo, do you have something you
Yes,
want to
I'll do the next question.
Okay.
Do you want me to do the next question?
Yes, absolutely.
Okay, great. Okay. So how do you interpret the importance of emphasis of self-efficacy in your patient's treatment plan and perspectives on yours versus their expected outcome realization?
I think that's a great question. I think I'll answer the second part first,
Yeah.
and that is how you manage expectations. And I think we haven't done a very good job of creating for the patient what their function is going to be after an intervention, what their function is going to be after a cardiac bypass, what's their function going to be after a knee replacement. And it's pretty common for patients to think, okay, well, I'll be back to the way I was when I was 15 and I could water ski like Ginny. And when that doesn't happen, there's frustration and a sense that the operation wasn't worth it, at least in my area of orthopedic surgery. So I think we've learned that we need to be honest and set expectations of what people are going to do, be able to do. Having said that, patients teach me every day how much more they can do than we ever thought they could do. Jenny's a great example, actually.
Mm-hmm. Yeah.
I almost choked the first time she told me she was going water skiing after her hip replacement, but she showed me she can do it safely and well, which is cool. So I learned from that.
She doesn't cross over. She keeps.
That's right. Remember, for slalom skiing, I ski like a left-handed person. My right foot's back. Huh?
See, there you go. Yeah.
Let's see, the first part of your question, Mo, self-efficacy.
Yes.
Well, I think that's an important part of it, and that may be a part of setting the expectations. But my expectation for patients, if you're not going to put into this what you need to put into this to get a good outcome, guess what? You're not going to have a good outcome. And I think that I'm fairly serious about that. I think most people are when we're dealing with patients, that we talk a lot about buy-in in any kind of treatment. I don't care what you're treating, but if the other party isn't bought into what your goals are in the treatment and is not willing to work towards those, it doesn't have a great chance of being successful. So I think that there are different tools to measure the degree of commitment that a patient has. As you know, there are all these patient-reported outcomes and patient-reported instruments that we're all getting surveyed out the wazoo, and that's how the apple cart's eventually going to fall over. You can't do 1,200 surveys a day, and it seems like that's what you get in your cell phone. So we're trying to figure out the minimum amount of questions to answer what we need to know about the patient's commitment and understanding of what the treatment process, what the goals of the treatment process are. But I think, we never used to do that. We used to say, for example, in my work, you have an arthritic knee, we'll do a knee replacement, and I'll see you later. And I think it didn't take us that long to realize that perhaps was a flawed concept, that we had to do a little bit more work on the front end in terms of optimizing not only patients' physical health, but their mental health. and then to support them in the rehab period when sometimes things get tough and it's easy to get depressed.
Don't you think, though, that there is a relationship with younger people as opposed to like the older generation? Because like my parents who are in their 80s, right? Well, you have surgery, you need to rest, don't move a lot, you have to rest everything. That's their mentality because that's what they were used to. And it's very detrimental because the hip can freeze. I mean, so many things can go wrong. I don't know if that's correct or not. I mean,
No,
do you see something?
I think it is, but I think everybody has a different capacity.
Okay.
Jenny may have a different ability to rehab in certain things than Mo does. And
Right.
I think it's up to the providers to assess what those differences are and to tailor the program to the patient. We talk about standardizing medicine for better results, which is true up to a point. But if you put everybody in the same box, you're not gonna get as good outcomes as if you figured out what their specific problems were and addressed them. So,
Okay.
Yeah.
That's a good answer.
Well, you mentioned the patient-reported outcomes, and a term that you mentioned in a previous conversation was the OSPRO, the Optimal Screening for Prediction of Referral and Outcome. So I was wondering, because I remember during my recovery and actually during the whole process, it was the activities of daily living, and so more of the physical recovery and all that. But now what you're saying is these are more patient-reported outcomes on psychological measures as well, or what exactly is the OSPRO about?
That's right. OSPRO is all about psychosocial comorbidities that the patient might have that we've shown in lots of articles can affect their outcome. OSPRO is just one of many tests that are out there. As you probably know, there's PROMIS, and then there's joint-specific things like the HOOS and the COOS, which are hip and knee specific outcome scores. So the OSPRO is the first attempt to try and break down the psychosocial problems that have been shown to have a detrimental effect on what we do. In my specific case, orthopedic surgery, but it goes way beyond in all other medical disciplines.
That's interesting, and it's all patient reported. So that's interesting, even from like what types of questions. I was just looking at some examples and asking the patient about anxiety and depression and different feelings they were having. And so do you find, so say they answer the questionnaire and then you're talking with the patient, do you find that they're pretty accurate on the self-reported for the most part?
Yeah, because most of those instruments are set up to try and pick up on people who are playing to an audience and are tailoring their answers that way. But okay. I would say that what screening instruments like the OSPRO do is identify potential problems, but it's up to the provider to verify that, yes, indeed, there is a problem, and then prescribe an intervention. And what we've done in Durham is to try and cross-train physical therapists to not only do the physical part of the job, but also to interact, screen, and try and modify people's mental health and behavior. Okay.
Yeah. Okay.
So a much more holistic approach to the whole person.
Yeah, I like that.
That's the best way to go, isn't it? I mean, it has to morph into that because it's just so important.
Yeah. I mean, if it is the best way, it'll become the most successful way. And I think that's what we have to see. But for all intents and purposes, it has grown very rapidly around our community, and I think it will continue to blow up.
Mm-hmm.
Yeah, good. Okay. Well, like we discussed earlier, there's strong evidence moving on with this, with CBT, cognitive behavioral therapy for patients pre, during, and post-treatment to help build confidence for physical recovery. And we read how patients can learn methods to mitigate episodes of kinesiophobia. And could you expound on this thought? And could you also please say the term correctly?
Kinesiophobia is fear of movement. So you do a knee replacement, and the patient is absolutely terrified that moving the knee will cause severe pain. And you can see it the second you lay eyes on them that they are getting inappropriately worked up about this pain, and those are the kind of people you would hope you'd picked up on beforehand and you'd done some intervention. But there are numerous things that are described, and it's pretty easy on the internet to look at therapies designed to address kinesiophobia, slow motion, certain ideation in the head before actual physical movement, and the same way with catastrophizing, say, for example, which is, kinesiophobia is probably an element of catastrophizing. And I think that, you all certainly are familiar at it from the delivering babies standpoint. How you approach the pain, how you work with that pain is vitally important to what you're able to accomplish, whether it's delivering a baby or moving your knee. And I think that one of the reasons Lamaze and other programs were so successful is that they addressed that in a positive way before the actual experience.
That's a good point. Yeah. Well, and like we had said before, Mo and I both had experienced total hip replacements, and I still remember that first time standing up after. But you know what? It was really amazing that the pain, the post-surgical pain, was nothing compared to what it felt like before surgery, right, Mo?
Right. Absolutely.
Yeah.
Absolutely. And I lived with my pain since I was 7 years old, and from Perthes disease. And it just grew and grew and grew and grew. And finally, when I was about 40, 41, I was just like, okay, I'm done. I can't deal with this. And it was starting to get to be bone on bone. And it was time to do it. And the minute I woke up, that arthritic, terrible pain just disappeared. It felt like a brick, though, when I woke up and stood on it. And I was like, what? It feels like a cement block. My dad's a bricklayer. I said, this feels like a cement block, And I stepped right on it. And, but I was up and walking within, I woke up out of the anesthesia probably 2 hours later. I was up and walking, and I haven't stopped.
I think our patients, you guys, are constantly teaching us what we can do. I mean, it wasn't that many years ago that people stayed 4 or 5 days in the hospital, and now they're going home as an outpatient, and just crossing that leap of faith that a patient could go home and be okay the night of surgery has been a huge step forward. And I think it appears to be that patients,
it was fine.
Many patients may do much better at home than they do in the hospital. So.
But I also needed some help at home. So if I were alone and single, I don't know if I would be able to do that on my own. Do you know what I mean?
That's part of the prep.
Right.
Your provider should say, what is it that you're going to need at home? And I think it's up to the providers to build the safety net for people. Right. And once you feel comfortable, okay, I got this. Because there are plenty of people that don't have any home help at home and go home and do very well. So it's a lot of it's mindset. What do you mean
Right?
I can't go home
Exactly.
the same day? Well, of course you
Yeah.
can, and people do it
Yeah.
all the time. So
Wow.
A
Wow.
lot of things are mindset,
Oh
that's
yeah.
right.
you
Yeah.
know.
We're
Yeah.
pushing ourselves to expand what we're doing. You know, there are challenges, whether they're viruses or
Yeah.
surgeries or pain. There are challenges out there, and we need to keep pushing through with solutions.
Right. Right.
So, Bill, you mentioned the kinesiophobia about the fear of movement. So, in addition to that, I was reading some articles about that idea in athletes, and there's a fear of re-injury as well. Can you speak to that a bit?
Sure. I mean, that's all of our biggest fears. I'm going to go through this big surgery. I'm going to go through this painful, exhausting rehab and then get hurt again. Um, you know, and helping people address the fact that, yes, you could get hurt again, but you're far more likely to excel. I think it's creating that sense of understanding in people and laying out risk and benefits to the patient is something that we're doing a better job now. And there's kind of a buzzword in surgery called shared decision making. It's not just in surgery, it's in medicine as well. But where the doctor and the patient look at the data, look at the patient's issues, and make a shared decision on what's the best treatment for them or what the treatment they want to proceed with. And I think that that goes a long way in educating. That's probably part of the therapy. Once you know what's coming, it's a little easier to manage it. And I think we didn't do as good a job of preparing people for what was coming 20 years ago as we do now.
Yeah. Well, mine was what, 19 years ago, and just thinking
Unbelievable.
about what.
Unbelievable.
I know, can you believe it? So, but just managing, like you were saying, talking about the expected outcomes, the expectations of the patient, and you do come out thinking, well, I'm just going to do everything. And I remember Brenda Gimmel there at the hospital. She was worked in joint replacement area, and she was always like, you just have to think about what are your incentives? What do you want to get back to doing or going forward? And so that's really where we have to come at it from an attitude and mindset perspective, is just, what are your incentives? And
That's right.
how are you going to help make that happen?
You as a patient have to identify what it is you want, what you expect the treatment to do for you to allow you to do that. And I think that puts a little bit more onus on the patient to come up with their goals. And then that's something that they can discuss with the caregivers.
Mm-hmm.
And it also gives you a new lease on life if you feel, if you feel positive about this whole experience.
Well, it empowers you too. You say, okay, it is in my control to define what I want.
Right.
It's within my provider's control to tell me what's realistic and what the risk and what the benefits are. And that now empowers me to make the decision that I think will be the best one for me. So
Yeah.
it used to be the doctor making the decision for you. Now it's more the patient. So.
Well, I watched your video on the Duke Health website, and one thing you mentioned, Bill, was the kind of doctors that your mom liked. The ones that, in your little minute video, you said the ones that would come and sit down and talk with the patient, eye to eye, and see what are your expectations?
That's right.
What type of care do you want, rather than one standing in the doorway, just, scheduling the next surgery, what have you. And that really spoke to me, because I like, that's the style that needs to be happening, especially if we're working in the mindset too, and letting the patient participate in developing their treatment plan.
Absolutely. You got it, Ginny.
Well,
We always learn the best lessons we learn in life are from our moms, I
Yeah,
think.
I like that.
Absolutely.
I like
They know
that.
us the best.
So something that Mo and I were talking about earlier today was talking about, developing new behaviors, healthy habits,
What was that
behavioral
term that I
change.
used? Do
Oh,
you remember?
well, we were talking about
I can't remember.
how healthy habits impact, I was looking at my notes, impacts the
Okay.
rehab and the healing, but you're thinking about the learned behaviors throughout their life. Is there a way that somebody can pivot into new types of behaviors after having an orthopedic procedure, for example? So what if they grew up with not eating healthy or not exercising or what have you? Is it difficult to change their behavior patterns, when they're having some type of orthopedic treatment, whether it be for arthritis or some type of procedure?
I think we used to think that it was, and we didn't perhaps work at it as much as we should. And, the classic things that we now know are very bad and increase your risk of surgery, like nicotine. We used to think, well, we'll never get people to stop smoking. And yet with current smoking cessation programs, it's pretty common. And the same thing is true with narcotic use. We get people off of narcotics before surgery. The same thing is true with weight loss. People used to be resigned to, I'm never going to lose weight. I'm going to be fat forever. It's not even worth trying. And the doctor would go, okay, well, I guess there's no point in trying. And I think it's been providers in those specific realms who say, no, there's things that we can do to intervene that will change fairly significantly the patient's outcome. And I think we can, it's not uncommon for me to have patients lose 50, 60, 80 pounds before surgery. It's not uncommon for them to stop smoking. It's not uncommon for them to get off of narcotics, which, 15 years ago, my jaw would have dropped. So, people say, oh, we're not making any progress in medicine. We're clearly making some progress in a lot of these areas.
I love that. I love that.
Yeah. Yeah.
So Mo, what else do you have?
Yeah, and I just have one more thing. What are your thoughts on the subject of resilience?
I think my thoughts are, you have to be able to recognize it first. And as a provider, I'm not sure I'm 100% good at picking up on that. You can pick up on that in the patient's history and things that have happened. You were in a severe car wreck, broke, half the bones in your body, crawled, were in bed for this long, and now you're walking and you're running and you're water skiing. That's a resilient soul. And I think I myself have been working on ways of identifying those people and ways of giving people who are not resilient some hope and some desire to work towards being resilient. So I just had a student who has submitted a paper. Did I send it to you? I should send it to you guys.
No, not yet. We'd like to see
I said I
it.
was going to, and I will.
Okay.
That there are, just like there's OSPRO, there are basic instruments, fairly short instruments that can, the way you answer it, give some clue to your ability to overcome affliction, which is resilience. And I think that we will, just like we're incorporating questions from the OSPRO into our pre-op evaluation, we'll probably incorporate questions from the resilience paper too. And I think we're still learning, just like I didn't really think significant weight loss, medical weight loss was really attainable, and I've been corrected significantly, and I don't really know if it's possible to change somebody's outlook from glass is half empty to half full.
Hmm.
But I think we ought to try.
Yeah, I
Mhm.
agree.
Yeah.
So this has been awesome. Bill,
Wonderful.
thank you so much. Are there any kind of final thoughts, words of wisdom you'd like to share with our listeners?
Yeah, I think vis-a-vis what we just talked about, it's very easy to get bad news and get depressed and totally turn turtle. And I think that there are plenty of people out there who can help you, number one, not get that way, and if you do get that way, come back. So I encourage everybody who thinks that it just isn't going to go well ever in their life to reach out for those. And I think you, Jenny, and Mo, I think understand a lot. And I think what you're trying to do with podcasts like this is help people realize how to get that help, how to identify that they're not right, and how to get that help. And the more we can spread that around the country, I think the better off we're all going to be.
Thank you.
I
Yeah.
like that. Thank you so much.
Yeah.
We're
You bet. It was great to spend a little time with you guys. Have a great
Yeah.
evening.
You too.
Thank you so
Thank
much.
you. Thanks for your time. All
My
right. Well,
pleasure.
it's been great with BMI Redefined with Jen and
Mo.
Mo, and thank you, Dr. J, for being here with us. And
Thank you so much.
we will see
And
you soon.
for the audience out there, if there are any of you that listen to this, a few likes would keep Jenny and Mo going.
That's right. That's right. Thank you so much. We need a couple likes, a lot of likes.
Oh,
Good night,
thank
everyone.
you. All right.
Good night.